because in a literal sense, that's exactly what that generation did. But not only did they just win the Second World War, they created our system of higher education. They created the interstate transportation system. They cured polio. They eradicated smallpox. They went to the moon. And they created these amazing social programs of the last century, the GI Bill and Social Security and Medicare and Medicaid. Now those programs and those policies were the vehicles through which that generation tried to make the better world for their kids and grandkids. And in many, many ways they did. Because of those sacrifices and those investments, my generation, the baby boom generation, has enjoyed more promise and opportunity than any other generation in the history of the planet. But at the same time, and very unintentionally, these same programs and policies laid the foundation for many of the huge problems we face today. An economy dependent on fossil fuel in general, and imported oil in particular. A medical system that threatens to drive the nation to fiscal bankruptcy. My generation has a similar set of challenges, and we have a similar set of challenges, as did the greatest generation. Now, they may not be as obvious as the threat of the Third Reich. They maybe are not as dramatic as a Pearl Harbor, or as obvious as the specter of a Nazi panzer division snuffing out the flame of freedom as it rolls across the face of Europe. But I can tell you this, our ability to get our arms around this particular issue, the healthcare issue, if we're successful, will have every bit as much an impact on the lives of our children and grandchildren as did the winning of the Second World War on my generation. The late John Gardner once said that we're all faced with a series of great opportunities, brilliantly disguised as insoluble problems. This, my friends, is one of those opportunities. Thank you very much. I'm told we have some time for questions. If anyone has any or comments. Yes, sir.
You stated that inevitably we will go to a two-tier microphone.
Well, there's a microphone. I guess I want you to go to the...
You said that we are inevitably headed toward a two-tiered structure in the future. And one of the requirements on that two-tiered system, which would make it acceptable, is equal qualitative care for both tiers. How is that possible?
Well, the fact is we actually have a two-tiered system now. I mean, there's two great myths in America. We don't ration health care in America, and we don't have a two-tiered system. And the bottom tier is not people on Medicaid. The bottom tier are the people who don't have any health insurance at all. Then you have another tier for Medicaid. Then you have a tier for Medicare. Then you have a tier for people with good workplace-based coverage. And then Bill Gates is in his own, Paul Allen are in their own tier. So we already have it. We just pretend we don't. So what I'm saying is that there needs to be ultimately some kind of, in my view, a portable floor of basic services. Services that basically are significant in terms of producing health, and that's where you would apply the value-based cost sharing. And it has to be defined. And the way I would define it would be through a transparent public process that prioritizes health services from the most important to the least important in terms of the health produced, very similar to what we did with the Oregon Health Plan. And everybody should have access to that. And it should be financed with public dollars. And you know, if you think about it, that's exactly where we're heading. The federal health care bill, although it does involve the private commercial insurance companies, and there's nothing wrong with that, the subsidies for employers, the subsidies for employees, the expansion of Medicaid is all extension of public dollars, but it's through this mishmash of categories. And at the end of the day, there has to be some, and so if you include, I think there's more than enough money in the system at $2.5 trillion to provide everybody with everything that's reasonably effective from a medical standpoint, but some of those resources have to be spent keeping out of the system on the front place. Will there be things that we won't pay for? The answer is yes. And I'll give you an example from the Oregon Health Plan. What we did with the Oregon Health Plan is we do have a prioritization list. There was a woman in Eugene about 2 years ago who was on the Oregon Health Plan, and she had a particularly aggressive form of cancer. And she had been given access to all the first-tier cancer drugs and therapies, and she'd applied for an experimental drug that was extraordinarily expensive and had almost very little impact on outcome, and she was denied payment for that. And there was a huge hue and cry, but it became obvious that people on Blue Cross didn't have access to that either. So there has to be a transparent process that basically, at the end of the day, makes some judgments about what we're going to pay for and what we aren't. That's the way I would do it. Because at the end of the day, what we're doing right now is we've got a system where we end up paying for extraordinary things like strokes when we could take pennies and manage people's blood pressure. So at some point we have to come to terms with that. Yes, ma'am.
You could call this silly, but I hear you inviting us to think outside the box.
Yes, ma'am.
We think about unintended consequences, and I wonder what the AMA was thinking when they invented Blue Cross Blue Shield. Okay? I would propose to you that if there were no insurance whatsoever, that you would have the effect of a real marketplace. The patients could come and compare costs and go where they knew that it was going to come out of their pocket and it wasn't someone else paying for it, because I think a very intrinsic problem with our system is the fact that we don't pay for our own health care. Someone else is paying for it.
Yep, I think there's some truth in that. Just a couple of comments, since I'm going to get on the plane tomorrow. You know, the medical insurance doesn't actually operate like other insurance. If you look at homeowners insurance or car insurance, you're insuring against something you don't think is going to happen. But if it does, the fiscal consequences are going to be enormous, and so you spread that burden across the entire population. Well, catastrophic medical insurance would work like that, but we don't spread it over the entire population. That's one of the things the federal government was trying to deal with. And a lot of it is cost shifting, cost avoidance. Pre-existing condition exclusions is a perfect example of not covering people because they might get sick. So, I mean, there's a fundamental problem with insurance as we know it applied to medical care. The second thing is, you're absolutely right. As long as there's no skin in the game for the individual, there are problems, and that's what I think. There's two sides to that. One is, I do think that some kind of value-based cost sharing is very, very important. But the other thing is, you have to have a system where people can actually price shop. I don't know how it is here, but in Portland, you could go to Kaiser Permanente, Good Samaritan Hospital, St. Vincent's, and Legacy if you wanted to get an elective cholecystectomy, if you want to get your gallbladder out. None of those hospitals could tell you on the front end how much that's going to cost. So until you have a more transparent pricing system, it's very, very difficult for people to actually shop for what's best. Yes, sir.
Governor, thank you very much for a really exceptional talk. I've heard you speak once before, and each time it makes me think more deeply about these issues. I wonder if one of the problems that we face that makes the knot so difficult to untangle is that not everyone has the same goal. We talk about the healthcare system, and you speak about reforming it. That would be like, you know, taking a team and saying, look, guys, we need a new strategy. We're not winning enough games. And the team says, you're right, let's do that. But the purposes of the various players in the healthcare system are extremely different. What, for instance, is the purpose of a corporation? A corporation, which is for profit, has a duty to its shareholders to remain profitable, to increase market share, to become more profitable. And if that corporation is United Healthcare or is one of the other for-profit health insurance corporations, then what we need to do is we need to look at the healthcare dollar, and we need to ask, okay, for each of those extraordinary measures that's denied, how large is the bonus to the CEO? How great is the dividend to the shareholder? Why are these people here at all? Why is the transaction not between an entity like Medicare, for instance, which isn't trying to make a profit, and the provision of health care.